the continuous update conference, and of course for the Radiology Intervention Department for this update and great continuous conference. Now we move for the next talk by Dr. Mina Emil, the Vascular Malformation Intervention Approach for Management. Dr. Mina.
صباح الخير. اولا حابب اشكر كل اساتذتي اللي موجودين، كل زملائي. حابب اشكر دكتور سامح ودكتور كريم على مجهودهم العظيم والجبار الفتره اللي فاتت، واقول للدكتور محمد شاكر جود لك في الفتره الجايه، ربنا يوفقك. We are going to talk about vascular malformations, interventional approach for management. We are generally going to talk about general classification of vascular malformation and basic or general approach to intervene with each type. First, vascular malformation management requires a multidisciplinary team, including surgeon, diagnostic and intervention radiologist, pathologist, internal medicine, or sometimes a pediatrician. In our hospital, we try to make a small team to assess and manage vascular malformation patients. This team includes my great colleague, Dr. Haitham Nasser, who first created the team and supported me a lot. My colleague, Dr. Ahmed Uqba, who is abroad now, Dr. Asma Nabil, and Dr. Hassan Al-Chazli. Vascular malformations, according to ISSVA classification, which is the International Society for the Study of Vascular Anomalies, is classified in its last update 2018 into benign, locally aggressive and malignant tumors, which is under the main category vascular tumors, and the vascular malformations, which is the main aspect of our talk now, which is further classified into simple, combined vascular malformations of major named vessels and vascular malformations associated with other anomalies. Vascular malformations can also be classified angiographically into two main categories: the slow flow category, which includes the venous and lymphatic malformations, and the high flow category, which includes the AVM and AV fistulas. Let's start first with the imaging. Imaging of vascular malformation, we will start with the venous malformation. First line in imaging, we use ultrasound. Venous malformation typically composed of small chambers on ultrasound with Philippoli, which are detected as masses with acoustic shadowing and are so typical of venous malformations. By Doppler, it is very helpful to distinguish high flow from slow flow venous malformations and to differentiate lymphatic from venous malformations. CT venography has a limited role in venous malformation imaging, as it is recommended only to identify underlying pathology, see obstructed veins, anatomical variation, and extent of venous thrombosis. By MRI, venous malformations look hypo to iso intense on T1 and hyper intense on T2 weighted images, and these features allows the differentiation of venous malformations from other high flow malformations like AVMs and AV fistulas. By angiography, these masses can present with a fistulous component adjacent to an artery. For imaging of lymphatic malformation, also we use the ultrasound at the first line. By ultrasound, lymphatic malformations appears either small cysts, which is called microcysts. They are less than 2 centimeters, and large cysts, which are called macrocysts. They have no detectable flow by ultrasound. Also, they lack Philippoli, which is very characteristic of venous malformation, as we mentioned before. By Doppler, they appear as hypoechoic or anechoic compressible channels with absent blood flow. MRI here is the modality of choice to determine the extent of lymphatic malformations. Lymphatic malformation cavities appears iso to hypointense on T1 and hyperintense on T2 weighted images, and they lack the flow void effect that can differentiate them from high flow vascular malformations. By contrast, lymphatic malformations don't enhance like venous malformations. For the arteriovenous malformations, ultrasound and Doppler is also the first line. AVMs appears as vessels with high systolic and diastolic flow, prominent arteriovenous shunting, and pulsatile venous structure. CT here is very important in arteriovenous malformation, as it allows a structural assessment of these lesions by providing useful information regarding adjacent organ involvement and the extent of the mass itself. By MRI, they present as network of arteries and veins connected by a shunt. They demonstrate flow void in T1 and T2 weighted images and the high signal intensity in T2 weighted gradient echo images. Unlike other vascular malformations, AVMs don't present enhancement of adjacent structure on T2 weighted image. In diagnostic angiography, they present as dilated veins, dilated channels with early opacification of a dilated vein. So what are the indications for treatment of vascular malformations? Indications include unsatisfactory pain relief using conservative measures, bleeding episodes, especially from superficial vascular malformations, or functional impairment and deformity. In cases of patients with extensive vascular malformation, the treatment is first focused to the symptomatic region. Okay, venous malformation interventional treatment. Generally, treatment is performed under general anesthesia. The region of interest is prepped and wrapped. Direct puncture using a 22-gauge butterfly. The venous malformation is accessed under ultrasound guidance, and digital subtraction venography is performed. According to venography, venous malformations can be classified into 4 categories, which helps to answer the treatment plan. Let's talk before the classification of venous malformation about the agents and tools used in treatment. Common choices for ablation tools and agents include sclerosants like 3% STS, absolute alcohol and bleomycin, endovenous laser, liquid embolics like onyx and glue, and mechanical occlusion devices like coils and plugs. Okay, the first type of venous malformation is sequestrated venous malformation with minimal venous drainage, like this one on the MRI. We see sequestrated venous malformation, and by digital venography, we see injection needle, which is marked by the black arrow, and the draining needle, which is marked by the red arrow, and then there is almost no venous drainage. Also, this diagram shows the first type. We have here a venous malformation with almost no draining veins. So how can we manage this type? The technique and agent used in treatment of sequestrated venous malformation with minimal venous drainage. Here we can use a technique called the double needle technique. We insert 2 needles. This is a venogram showing the venous malformation. We insert 2 needles, a distal needle and a proximal needle, into the venous malformation. We inject the sclerosant through the distal needle, and the proximal needle is very important as it may provide a low resistance pathway for the sclerosant, and this helps to prevent overdistension or extravasation of the sclerosant. Mechanism of action of STS, it induces endothelial cell inflammation, which leads to fibrosis. Okay, how we can prepare the STS? STS, we can mix it with ethiodol or lepidol and air in a ratio of 8:2:5. This helps us to create foam, and the detergent properties of STS allow the formation of microbubbles. These microbubbles decrease the risk of extravasation and increase endothelial contact time. Injection of STS foam, the foam is injected under ultrasound and roadmap imaging. Post-procedure venography is done to assess the patency of deep veins, and the treatment plan can be done every 6 to 8 weeks interval until endpoint is reached, followed by MRI after 3 months. The second type of venous malformation is venous malformation draining into normal vein, or venous malformation which has a slow venous drainage. Here we have a digital subtraction venography showing the venous malformation marked by the red arrow, and there is normal small draining veins marked by the black arrow. The technique here and the agent, we also use the double needle technique, and we can use here STS or absolute alcohol. How alcohol works: alcohol causes protein denaturation and dehydration of endothelial cells with instant platelet adhesion and thrombosis. In addition, there is pronounced inflammatory response leading to fibrosis. Although alcohol is more potent than STS, it has higher local and systemic toxicity. It is therefore less favorable agent for superficial cutaneous and mucosal venous malformation, as well as those close to major nerves. The concentration of alcohol, we use 98% concentration, and the dose is 1 milli per kg, and the maximum dose is about 40 to 50 mils. The third type of venous malformation is that type with drainage into dysplastic veins and venous malformation which show rapid venous drainage. In this case scenario, we have a big problem. The draining vein might be very fast, which in this case gives less time for the sclerosant to contact the endothelial wall. So most of the sclerosant injected is drained rapidly to the draining vein. This type of venous malformation, we use either liquid embolics like onyx or glue, or mechanical embolics like coils to occlude the draining vein. And this helps us to allow sufficient time for the sclerosant to act on the endothelial wall and produce fibrosis later on. In this type, we may sometimes use tourniquet, but tourniquet is less favorable, as it may cause overdistension of the venous malformation and the extravasation of the sclerosant. The last main type of venous malformation is that venous malformation draining into dysplastic veins. As we can see here, there is a venogram showing anomalous vein marked by the red arrow, and the normal anterior tibial veins marked by the black arrow, draining into the doubled popliteal veins marked by the dashed black arrow. In this case, for treatment of dysplastic veins, we use coils or plugs. Large dysplastic veins need occlusion with precision using mechanical occlusion devices such as vascular plugs and detachable coils. This may be combined with liquid embolic agents. Okay, we have another types or subtypes of venous malformation in special locations. Like this one, venous malformation here is near the airway. In this scenario, we use sclerosant which causes less inflammation, because we are afraid there is a pronounced inflammatory response which can occlude the airway. The technique here we can use is the double needle technique, and the sclerosant is plumicin. The mechanism of action of plumicin is a cytotoxic antineoplastic antibiotic. It induces single and double-stranded DNA breaks, and it is an endothelial sclerosant. Of all agents, it causes the least amount of inflammatory response and is useful for treating intramuscular, orbital, and airway-related venous malformations. The concentration is 1 unit per milli, and we use 0.5 unit per kg, and the maximum dose is 15 units per session. Another special location is extensive body wall venous malformation. The problem here is that large extensive venous spaces require a large volume of sclerosant for treatment, which increases the risk of local and systemic toxicity. So we can use here endovenous laser ablation. We can use a 5-French sheath to access venous space under ultrasound guidance. Then we ablate using the laser fiber, and the remaining part we can do with sclerosant. The second type of slow malformation is the lymphatic malformations. The agents and tools used for lymphatic malformation. The first drug is doxycycline. This is the most commonly used agent. It is used in a concentration of 10 milligram per milli, and it has a very low local and systemic toxicity. Bleomycin again is used for superficial, intramuscular, and orbital lymphatic malformations due to its advantage of causing minimal swelling. STS and alcohol are used for lymphatic malformation that don't respond to doxycycline. Also, laser ablation if we can find sufficient channel to be ablated. Technique for lymphatic malformation. Under ultrasound guidance, we cannulate the lymphatic cysts. Macrocysts greater than 2 centimeters are typically cannulated, and aspiration is done to aspirate about 80 to 90% of the cyst fluid, followed by injection of the sclerosant. Microcysts, which are less than 2 centimeters, can be cannulated using a needle primed with a sclerosant without prior aspiration. Okay, now let's go to the high flow vascular malformations. This is very important, defining the angio architecture of the high flow AVMs determines accurately the endovascular management strategy to best permanently ablate the AVM requiring treatment. High flow vascular malformations are classified according to Yax classification into 6 types. As you can see here, the first type is a direct connection between the artery and vein, which is a fistula. Type 2A and type 2B, there is a nidus. In type 2A, the arterioles drain into a nidus and the nidus to the venules. In type 2B, the arterioles drain into a nidus and the nidus later on drain into aneurysmal vein. Type 3 and type 4, there is an anomalous aneurysmal vein. In type 3A, multiple arterioles drain directly or with a fistula with the aneurysmal vein, which has only a single vein outflow. In type 3B, there is multiple outflows. In type 4, there are innumerable fistula, which are mixed with the normal capillary bed. Okay, for the technique can be done under general anesthesia. For young patients, we can use 4 French arterial sheath, and for patients greater than 10 kilograms, we can use 5 French sheath. The main goal to treat vascular malformation is to deliver the embolic agent into and ablate the AVM nidus and its proximal draining vein while avoiding reflux into normal arteries and veins. Here, the agent used in treatment of high flow vascular malformation include sclerosant like absolute alcohol, liquid embolics like onyx and glue, and mechanical also occlusion device like coils and plugs. Treatment approach, unlike venous and lymphatic malformation, which require direct puncture, high flow vascular malformation intervention treatment approach can be transarterial, transvenous, plus or minus direct puncture. For lesions like which have simple nidus or diffuse infiltrative nidus like YAX2A and YAX4, treatment is initially attempted through intra-arterial approach. We advance the guide caster followed by microcaster, and we do further angiography till we find the perinidal location. Then we can use alcohol to permanently ablate the nidus. This case we have done in our unit with Dr. Haitham. This is a male 15 years old patient with AVM around the right elbow. Catheterization of the right axillary artery was done. And it showed an abnormal vascular channels with a draining vein around the lateral aspect of the elbow. We advanced the microcatheter. We injected here via the microcatheter a mixture of glue and lipidol under fluoroscopy guidance. So what are the challenges we can face in treating high vascular malformation? We have two main issues. The main issue, if we can't find the perinidal location. Here we can use direct percutaneous approach using a 19 to 25 gauge needle. And the second channel is that if we face rapid shunting or rapid venous outflow, here we can use tourniquet or other liquid embolics to occlude the rapid draining vein, then we can inject the nidus. This is another patient with a vascular lesion around the left upper zygoma. Angiography here was done using a microcatheter. Here we injected a mixture of glue lipidol. This is the control angiography showing adequate embolization. Regarding the other types of VX classification, here embolization is preferentially performed using transvenous approach, plus or minus direct percutaneous puncture of the nidus. Our main aim here is to occlude this aneurysmal venous outflow. And this is to sum up. The approach and the agent used in high flow vascular malformation treatment based on EX classification. So for type 2A and the type 4, we can use either arterial approach or direct nidal approach. And for type 2B, 3A and 3B, we can use venous approach plus or minus nidal approach. Thank you.
Thank you, Dr.